My name is Cassoobhoy, and I'm a member of the Medical Advisory Board at the Georgia chapter of the Scleroderma Foundation. And I hope today's talk will give you some valuable information on how to be prepared for a medical emergency, as well as a lot of tips on how to better navigate the medical system as a whole. My connection to scleroderma is a personal one. My sister was diagnosed about 15 years ago, and at that time I had just completed my internal medicine residency at Emory University, helping her navigate the medical maze living with a chronic illness, and myself practicing as a general internist. I think I've really have had a unique view over the last 15 years of both sides of the medical system. And the last 10 years or so, I've been working as a hospitalist, working in a community hospital setting, and again, taking care of a lot of patients with different illnesses. And so my hope is that today I can pass along this kind of bridge between the two sides that I've been able to see and help with firsthand. For those of you that don't know who a hospitalist is, how many of you know who a hospitalist is? Okay, half of you. If you don't, then you probably haven't been admitted to a hospital recently, and that's a good thing. And we'll talk a little bit more during my talk of what I do. The goals of my talk today are fourfold. The first one is to help you all put together your medical information in one easy packet that you can use and pull out anytime that there is an emergency. And we'll go through this great handout that the Scleroderma Foundation has already put together. And we'll talk about how you can use that to personalize it with your medical information and then use it in the future in case of an emergency. The second goal I have is to kind of walk you through and navigate if you have to go to an emergency room and you get admitted to the hospital, what all the different people you might encounter and the systems you might encounter, and how you can help understand and be proactive about your care, which goes into the third thing, which is how to be proactive about your health care in terms of staying safe in the hospital, in terms of being a partner with your medical team, and being proactive about being involved in your care and your decision making. The fourth thing, I think, which is one of the most important things, is to hear your thoughts and experiences. And I joke with my sister that she has two full-time jobs. One is that she works for a lawyer's office 40 hours a week, and then the second is being a professional patient. When you live with a chronic illness, unfortunately you have multiple specialists that you're seeing, different procedures and tests, and to juggle all that with your regular life, to me, it's a full-time job. And so you here have a lot of tips and tricks that you've learned along the way, and I think sharing that with this group is extremely helpful. I've learned a lot. This is the third time I'm doing this talk, my third conference, and I've learned a lot, and I know everybody in the room really benefits from hearing what each of you have learned along your way living with this illness. So hopefully we'll have some time at the end of this talk to go through that as well. Let's just start with how to organize your medical information in an easy-to-use sort of way and keep it accessible. This is the handout that the Scleroderma Foundation has put together. And what I recommend is putting this in a Ziploc bag or something. And the other thing that sometimes is just using a suction cup to put it on your refrigerator is one way. Keep it in a drawer that you know where it's going to be if you want to keep it private, but keep it very accessible. Do not put this in the safe deposit box. Unfortunately, we get so many patients who come to the hospital and we ask them, advanced directives or other documents, where are they? And they say, oh, they're in the safe deposit box, and but nobody knows where the key is. And they're sick in the hospital, and it's really hard to find all that information that they took the trouble to fill out and took the time. So it's really one of the key factors. And when you get this information together, keep it accessible and available and easy for someone to get. If you are at home, When you have to go to the hospital, you can just grab it immediately. If you're in the hospital, you can send a family or a friend to go get it from your home. Have multiple copies if possible too. If you go through the trouble of filling out this stuff, it's really keep multiple copies. I hate to hear that when my patients tell me, oh, we gave it to the nurse last night in the emergency room, and then nobody can find it or something. So always keep multiple copies if possible. The packet itself is organized into this list of information. The first one, we'll go through each of these. The first one, the first page, which I think is really great information about Scleroderma basics, and it's meant for the first response or response provider like EMS, information for them. Unfortunately, when they're dealing with an emergency situation, they're not going to have the time to look at this and read through all this. So it's really imperative that you or your loved one or your support person, your family, they kind of know this information about Scleroderma so that they can relate to the EMS provider, the emergency room nurse, the emergency room doctor. And the information that it really contains are a few of the basic things that when you have Scleroderma, you may already know. Pulse oximetry is considered like a fifth vital sign, and that's something that they'll try and get on you immediately. And with the Raynaud's and the finger issues, it's very hard. Sometimes you know which finger will work easier, so just let them know so they go right to that finger. A forehead pulse oximeter or using the earlobe can be other places that you can tell them to get your oxygen level, and that can help them a lot. Also, getting an IV access is very difficult because of the skin issues with Scleroderma. So letting them know if you have a place that is easy to get IV access in, pointing them to that area so that they don't stick you multiple times. And having them place a warm compress sometimes, if they can't see the vein or feel it, will help dilate the vein, and then it can be easier to get an IV access in there. In the hospital setting, if you have difficulty with IV access and you know that you're going to be receiving IV medications for a few days, you can ask them to put a longer IV line in called a PICC line, which they can use to draw blood and administer medications and avoid sticking you. So that can be something you can talk to them about. The other section that you want to fill out, which is really important, is your medications. And it's all your prescription medications, obviously, but also any over-the-counter medications, herbal supplements, vitamin supplements that you might be taking. You want to make sure you include them in this list. It can be very helpful, again, for the hospital or doctor who's seeing you to have the complete list and be aware of any interactions based on what you're already taking. You want to update them. This is one of the things I see very often. They'll have the list of medications, the patients, but then they will say, well, I know he changed the dose last time I was there a couple of months ago, so they're not sure which dose they're taking or which one they stopped. And so if you can kind of update them, what I mentally tell my sister to do, and is just to go ahead and always just change it as soon as after the appointment, so you have a running list of your current medications. You also want to include your allergies if you have any allergic reactions or side effects of medications. And there's a big difference between an allergy to a medication or a side effect that's an allergy. A true allergy precludes the use of that medication and that class of medication. So a true allergy is really swelling of the tongue, the lips, throat, obviously, difficulty breathing. Those are signs of a true allergy. A skin rash or hives that's directly related to medication is also a true allergy. And those are, you want to write down the reaction if you know to the medication. Because if you just had nausea, vomiting when you took codeine or something, that's not a true allergic reaction. A lot of people sort of get labeled as allergic to this whole class of medications in the hospital when they can really use that medication and it can help them. Penicillin is a common one that all of us think, oh, in childhood my mom told me that I was allergic to penicillin. They're not sure what reaction they had. If you don't know, sometimes it's good to let them know that you don't know what reaction you had and was in childhood, and it may not be something that you're still allergic to. So you want to be aware of those things. The other thing that's really important to fill out on this form is your problem list or medical history and surgical history and procedures that you've had. They have this table in the handout that you can fill out, and then they also have surgical history. You can use both of these to just kind of list, if you can, chronologically, just kind of, so when you started the earliest procedures to, as you add the procedures, the date that you had the most latest procedure or surgery. I also recommend for patients with scleroderma to put any tests that they had, especially like echocardiograms and catheterizations and those types of things, cardiac catheterizations, on this list, because even if you don't have the results on there, if you put where you had that test, they can easily, the hospital can easily get those results then. But there's no point repeating tests if if you've already had them and procedures. So try and keep a running list if you can of those types of things. Any hospital admissions as well. The other thing that section that is included in this is whether you have an advanced directives or not. And the advanced directives in most states is really a 3-component document. One of the questions here is, do you have a emergency contact or power of attorney? And that's one basic part of an advanced directive, is assigning a healthcare agent. In most states, it's going to be your next of kin. There's an order of hierarchy of next of kin: spouse, children, parents, siblings. If you don't assign a healthcare agent, those are people that are going to make decisions on your behalf if you can't, only when you can't. If you have someone that's important for you, that's not your next of kin, you want to make sure that you've filled out a healthcare agent or healthcare directive and name them your agent, so that they are aware, and you've got to let them know that you're naming them and have a conversation with them, and then include them as your healthcare agent to make decisions. They only can make decisions when you are unable to. So just assigning them does not give them any power to do anything unless you are not able to make decisions. Also, a living will is part of an advanced directive, and every state has their own form that you have to fill out for that, and you can outline your wishes in case, again, you're too sick to make decisions. It can help your doctor, your medical team, and your healthcare agent make decisions on your behalf. And that's usually a separate document that I recommend keeping with this document in a packet together, and again, not keeping it anywhere that you can get easy access to. The third part about an advanced directives is a do not resuscitate order, and that's really for someone to think about if they're very sick and have a very poor quality of life and they don't want to be resuscitated necessarily in the hospital if they pass away. It's an order that only goes into effect if someone actually passes away, they have no heartbeat or are not breathing, then it tells the doctors not to resuscitate them or try and bring them back. And again, it's a very specific order that you may have filled out during your advanced directives, and this document kind of asks you if you have that filled out. But those are really important things to think about to be prepared. Advanced directives in general, unfortunately, how many of you have advanced directives? Can I see a show of hands? 1, 2, 3, 4, 5, 6. 7. So a little more. The national average is about 25% of people that get admitted to a hospital have. So we have a little more in this group, and that's because you're such a group that's a little more active in your healthcare already. By being here at this conference, we know that you have taken an initiative to be involved in your healthcare. So that's a little better than the national average. But unfortunately, advanced directives is something we're really behind as a society. We fill out wills, financial wills, we fill out we have life insurance policies, but most of us don't like to think about filling out an advanced directives when unfortunately, for all of us, it is part of all of our lives. It requires planning ahead. Again, keep it accessible. It's a legal document, but it doesn't have to be filled out by a lawyer. In most states, you don't necessarily, you can have witnesses sign it if you fill it out. Typically, when you do your wills or estate planning, it should be part of that, and you can ask your lawyer to help you do that. And then, just so you don't get nervous, every time you are admitted to a hospital, it's a federal law to ask about having an advanced directives, and that's why they've just done it across the board. Ask everyone, and if you're in the hospital, they can help you fill one out while you're there if you're interested in doing that. And then my real take-home point about advanced directives is that the most important aspect of this is to really have a conversation with your loved one or healthcare agent. And I know it's really, really difficult. There are lots of tools. There are lots of booklets. There's one called The 5 Wishes. There's one called Critical Conditions that can kind of walk you through this process. They're available on the internet. So just have the conversation. That's even more important. Yeah. So a healthcare proxy is part of an advanced directive. The healthcare proxy is who you assign to make decisions on your behalf. So it's one of the components of an advanced directive. The second component is outlining your wishes. If you'd want dialysis, if you would want feeding tubes, if you would want to be on a ventilator, those types of things. And then the third thing is that do not resuscitate type order. So those are the three components of. You can fill out one part if you want to in most states. You can just fill out a proxy and not fill out the rest if you don't want to. The last thing I want to just talk about with advanced care planning is about something that you'll start to see more of. It got approved in 1995, and it's something that about 25 states now have approved as a way of communicating end-of-life wishes. Patients communicating end-of-life wishes. And this is really, hopefully, none of you have to worry about it for a long time, but it's really for the last year of people's lives when they were very sick, they have repeated hospitalizations, and the hope was that it got doctors to start talking about these things. Because unfortunately, just like you all, as physicians, nobody really wants to talk about these things. And by passing the law that allowed this document to be approved, what their hope was that it will make doctors in the last year of someone's life to really bring up these issues and outline their wishes before they get so sick that they can't discuss this anymore. And it's called a physician orders for life-sustaining treatment. And again, you'll see more and more of it, but it's another piece of the puzzle in our advanced care planning or end-of-life planning that you might hear more about. Okay, so that was how to have your information, all the information you need to kind of be prepared for a medical emergency. We'll lighten it up a little bit, and I'll give you some of the medical lingo we use. We try and, as we're getting more cautious about patient safety and stuff, and just for a good patient care, when I was teaching residents and students, I told them to avoid lingos, but unfortunately, if you're in the hospital setting, sometimes you'll hear these things. SOB is one. That I really tell them to avoid, but it just means short of breath. So if you hear it, that you're just short of breath. LOL, we all think about as laugh out loud, but in the emergency room, if you hear a nurse saying LOL, what she means is a little old lady who may be in the other room or you. M&M is not the candy for us in the hospital. It's a conference we have called Morbidity and Mortality Conference, where we talk about cases that that had unforeseen events or somebody that passed away in the hospital. We try and review the case and figure out what we could have done differently. That's an M&M conference. A hard stick, any of you know what a hard stick is?
A hard stick.
You've heard that before. When you have difficulty with IV access.
My daughter, they can't even use a PICC line. They go straight for a central line.
Central line, yeah. It's unfortunate.
Yeah.
But yeah, so she's a hard stick, unfortunately.
She has no veins at all.
A drip, anyone know what a drip is?
Yeah.
IV, yeah. So any kind of IV medication or IV fluids. And then ICU, we all know what an ICU is, right? Okay, but what about this? Now I know why they call it ICU. Okay, so moving on to our second objective, which was just to kind of walk you through what happens if you ever have to come through to a hospital. Most times people come through an emergency room setting. We'll talk about hospitalists. That's what I do, and what our role is. Obviously, you have subspecialty doctors in the hospital. You have nurses. You have social workers, therapists, educators, and we'll just kind of briefly go down what some of these people do. In the emergency room, one of the things I get asked about a lot from friends and families, I'll get calls, is is it something that I need to go to the emergency room for, or can I go to an urgent care center, or can I go to a primary care doctor? And obviously, if it's a true emergency, life-threatening emergency, you need to call 911, go to an emergency room. You've heard that disclaimer on all the times you call the doctor's office. But a lot of times, if it's not something very serious, you should really, call your primary care doctor, call your rheumatologist. They usually have someone on 24 hours availability that can call you back. And a lot of times they can kind of reassure you whether it's something you need to go to the emergency room for, whether it can wait the next day for an appointment in their clinic, whether you can go to an urgent care center. And these days, in most communities now, you have urgent care centers that have shorter wait times and stuff. Again, when you have a serious type illness like scleroderma and with different possibilities of different complications, you want to be very careful and judicious. But use your primary care doctor or rheumatologist to kind of figure out how serious it is and how quickly you need to get there. In the emergency room, you'll encounter triage. In the emergency room, we don't see patients on sort of first come, first serve. They triage you, and so if they deem that you're not, your vital signs are stable and they don't feel that you're that life-threatening, you have a life-threatening illness, you may end up waiting a while, unfortunately, and that's just kind of how it is because they're trying to triage the patients with life-threatening illnesses first. You'll obviously, see doctors in the emergency room, but these days just be aware mid-level providers in medicine are the norm in almost any setting, nurse practitioners, physician assistants, and they're really useful. They have more time to spend with you, taking your history. You can explain to them your scleroderma, talk to them, educate them probably on, and the doctors on, what you know about your illness and how you think it might be related to your emergency right now. But just know that they're there to help you too, and a lot of times they're transition before you see the doctor. And then in the emergency room, their main sort of focus for the physicians, the team seeing you there, is to kind of figure out if you have something life-threatening, they're there to stabilize you, get you stabilized medically, and then also decide whether you need to be admitted to the hospital. Obviously, if it's life-threatening, they're going to admit you. If it's not life-threatening, they're going to try and treat you and then decide whether it's something you need to be admitted to the hospital for. They use observation units. So a lot of times if you have chest pain and they want to just make sure you're not having a heart attack, they'll put you in an observation unit. They may not really fully admit you to the hospital. But that's sort of their algorithm, is to just kind of figure out, is it life-threatening or not? Can stabilize you? If it's not life-threatening, can you be treated as an outpatient, or do you need to be admitted to the hospital? This cartoon says, everyone is here to save you, but unfortunately not in the computer yet. So you have to register and triage before you can. Okay, so hospitalists. So that's what I do. I've been doing this for the last 10 years. And when I finished my training, it wasn't really, it had just started to become a specialty, and it's really grown tremendously, and almost every hospital in the country now has hospitalists. And you can really think of us as your primary care doctors in the hospital. Yes?
The one thing, though, that I have found with hospitalists is that, and this is nothing against you, is they sometimes try to override the doctor who knows the patient better by saying, you should be discharged. No, she can't be discharged.
So, I think it's if you have, there are lots of different strategies to communicate with your hospitalists. I think one important thing that I find is that when you have a really strong relationship with your primary care doctor or rheumatologist, I see this with rheumatologic patients, with oncology patients specifically too. They really have a strong relationship with their specialty doctor. What you can ask them to do is call your specialty doctor and just kind of talk to them and make sure they know what's going on, and let them know that your doctor is very involved in your care and that they do want to hear from them every time you're admitted to the hospital. A lot of times you can, if they shouldn't give you a hard time about it, but if they do, you can always call your rheumatologist up and let them know you've been admitted to the hospital and that you really want them to talk to your doctor so they understand your illness and treat you appropriately. Our specialty is really meant to communicate with your primary care doctors, with your rheumatologists, with your subspecialists, and let them know. Unfortunately, they don't always have the time because they're so busy in their outpatient practices to come see you in the hospital. Many of them will be able to, but some of them, it's just hard for them to come the first day or the second day sometimes. But our job is really to communicate with them, and we love subspecialty input because, especially when you have complicated patients and they have a relationship with their doctor, I value the first person I call when I admit a patient with cancer is their oncologist to figure out, what they think may be going on and to help me kind of figure out what to do next. And the same thing with a patient with a rheumatologic illness, with lupus and scleroderma that we admit to the hospital. We contact their rheumatologist and kind of figure out the whole discharge issue. That's a very multifactorial component to it, when someone's ready for discharge. And we are the primary admitting doctors, so we are responsible for discharging them. And if you have an issue with being discharged too early, talk to them, try and figure out why they think you should be, why they think you are safe to be discharged. If you disagree with them, you can appeal that decision through your insurance company or take it to a charge nurse or a patient rep. Ask for a different hospitalist if you want to speak to a different hospitalist to get another opinion. I know it can be very hard in those situations, but
Not if you go to the same hospital all the time.
and they know you, so that's
Right.
better experience.
And not only that, my daughter for 23 years was a nurse in that hospital.
Oh, well, that's so
So that helps too.
Absolutely.
She knows the right people to say, Mom, go to this person, go
All
to
right.
that person.
Do you have a question with that?
Yes, so so you become the hospitalist for the patient who's been admitted either via emergency room or by a specific doctor. So you are the treating physician for that patient?
So most subspecialists now very rarely admit to the hospital under their sort of name. They're not the attending. So even if you're a rheumatologist, he might say, oh, you need to be admitted, your infection in your finger is really bad, you need IV antibiotics. Some will admit you under their name and not involve a hospitalist. But in our hospital in the last 5 or 10 years, no rheumatologist, no GI doctor has ever admitted a patient, oncologists even. They have us admit the patient and they'll come see them if they need our help. So we become the attending doctor. We kind of become the medical doctor that you're going to see in the hospital. And then their subspecialist will consult them if we need their help. Or if they know you already and they want to be involved, we're happy to again have them involved. But we're your attending doctor. We do the admission, we do your orders on sort of a daily basis, and then we do your discharge. Yeah, so this is the way most hospitals function now, because unfortunately the primary care doctors and the subspecialists, they just have such a busy outpatient practice, and patients in the hospital have become so sick that they really need someone there 24 hours. And we're there 24 hours in the hospital.
Yes, but you still don't know the patient's history.
Right, and that's our job, is to learn the patient's history and if they bring this in with them and we have records.
Walk into a room and say, what brings you here to, well, this,
Right.
don't walk in.
What's your normal rotation? I mean, I know you all rotate in and out, and I think that's sometimes difficult for
Right.
patients to have several of you attend to them. So what is the normal?
So normal rotation, it's a cycle, usually 7 days in a row at our hospital. It can vary from anywhere from 4 to 7 days. So typically, unless you come on a day that you see a doctor and then they rotate off and you see a new doctor, typically you should see that doctor for the next few days, minimum of 4 days. Now obviously sometimes they switch, people switch around and stuff, but the whole, the schedule is made with the concept in mind that you really want to have a block of time that you're seeing. Most of the patients, when I'm doing my 7-day block, I admit and discharge, and they never see another doctor in that 7-day block. Then the overlap happens if they get admitted later on in my schedule, and then I have to hand them off. And usually, again, if you have a hospitalist, they let you know that the next day you're going to see someone else, and we're usually trying to really communicate when we're handing off patients that these are the issues that are ongoing with this patient's care, and dictate them. And yes, they should be looking at your chart and doing all that, and not having to kind of recap everything that's happened. Yes, sir.
It's not specifically about hospitalists, but going back to emergency rooms, one of the things that we've experienced is we've got 3, actually almost 4 hospitals in the area, and my wife's been to all 4 emergency rooms. And procedures at each emergency room are entirely different. How or is there some process where the emergency rooms are all going to get it all together and we do all the same things at the same time and in the right order of things? Is that something down the pike, or is that a goal that you guys are striving to do?
Well, I think, the emergency room, they see such a multitude of problems and patients and things that they see. We have really tried in the last 10, 15 years in the hospital system to standardize things. So for pneumonia, we have what we call clinical pathways. So if somebody we think has a pneumonia, they kind of try and be very consistent in getting the antibiotics, administering the antibiotics quickly, figuring out whether they need to be admitted to the hospital, making that decision quickly. And for heart attacks, strokes, they've really tried to streamline some of those processes that are very common. I think when you have things that are less common and rarer, then it may seem that they're doing things in a different order. Patients that have, unfortunately, uncommon illnesses like scleroderma that can affect so many different organs and may or may not be related to the reason you're in the emergency room can complicate things a little bit and make it really harder to seem to, have a streamlined process in place. So in general, I agree with you. It's hard when you have a rare or uncommon illness, but if you're coming in with something that's more common, usually they should have a streamlined process. A lot of for chest pain, they have observation units set up so that they can observe a patient for less 24 hours or so, and those types of things. So they're supposed to have processes in place, but unfortunately, every emergency room, every hospital, they really have to. Even though we try and be consistent in the quality of care and everything, there are differences in the way they deliver that care. And you may figure out what works for you, and that's part of your role as a consumer, figuring out which emergency room really seems to have their act together and helping you and being consistent and doing the right thing. And so that I'll talk a little bit about that, how these days you can look online and compare different hospitals, different emergency rooms, and how quickly they're seeing patients, how quickly they're administering antibiotics for pneumonia, what their death rate is when they treat people with heart attacks, what their complication rate is when they have patients with stroke, those types of things. So we have access to all that information now. It's still in the early stages, and I'll talk a little bit more about that, but you do have that online, and you can put reviews on now and stuff too, so you can really sort of shape that as well.
Fortunately, also, you can tell the EMS where you want to go, so that helps a lot too. Which hospital you want to go to.
Right. Yeah. Yes,
A question, sir. Are there medicalists who, in the hospital, then have specialties? So if someone's coming in for chest pain, someone next door broke their leg, is there a person who would then kind of say, all right, I got the chest, I'm more of a specialist in that? Or would you have like one person on who would say, I take all scleroderma people? You know what I mean? Just
Right,
so that you're better educated in that area.
So
And then my second question
Sure.
was, as far as advocating for family members, when people are admitted under observation, sometimes the insurance treats it greatly different than they would if they're just admitted. Do doctors understand when they make that decision to say, I'm admitting you to observe, or I'm admitting you? Do they understand the numbers behind that?
Right.
And what that might mean to an individual patient?
Yeah, so that's a very good question. So the emergency room doctor is the main doctor who will decide who admits the patient to the hospital depending on their problem. So if you have a fracture, they're going to call the orthopedic team first. And the orthopedic team, especially if they think that their patient will need surgery, will usually admit them. But we as hospitalists, we admit a lot of patients with hip fractures because they're usually older and they have so many medical problems going on like diabetes and kidney problems and lung problems that we'll admit them, and then they'll kind of do their surgery. They'll see the patient, do their surgery, and then let us kind of deal with the recovery after surgery. So in general, hospitalists are admitting more and more patients, unfortunately, because people are sicker and older and just have so much going on that it's hard. The orthopedist really just wants to deal with the fracture. If you have heart issues, if you have lung issues, the hospitalist determines whether they need help from a cardiologist. If they think you're obviously having a heart attack, they're going to let the cardiologist know immediately. If you're having a severe asthma exacerbation that we can't take care of with medications, regular routine medications, then we'll call the pulmonologist in to help us. If you go to ICU now, most ICUs have specialists working there too. So it is we're kind of like your quarterback at after the emergency room, we're your quarterback trying to figure out who can help you best. If it's a general issue, we can help you. If it's not, we get the subspecialists involved. Does that help your first question? The second question about the admission observation status, that is a big issue with Medicare especially, because they have the patients are responsible for different payments if you're admitted under observation versus full admission. And it's a very unfortunate type of Medicare rule, and they're looking into changing that. And it's based on time. If you think you're going to spend less than 2 nights, just arbitrary, less than 2 nights in the hospital, then you may be admitted under observation status. The hospital emergency room is supposed to let you know that you're being admitted under observation status. The financial people who come and tell you, because there may be different co-pays associated with being admitted under observation status versus inpatient. Unfortunately, it's sort of a Medicare mandated thing on the hospitals and doctors to, if we think you're going to be less than 48 hours in the hospital, we have to admit you under observation status. It's sort of mandated on us to do that. If you don't get discharged within 48 hours, so we will change it over to a full admission. And that's, and then the Medicare will consider it to be a full admission. But we have to make a lot of calls to insurance companies. Sometimes Medicare, the secondary payers that Medicare contracts with, to justify whether somebody was observation, somebody was admission, and all those types of things. So unfortunately, it's a game we all have to play with the insurance companies, but they should let you know up front which status you're being admitted under. And it's a good point to find out, are you being admitted under observation or admission status, because your co-pays might be different. In terms of the nurses that you see on the floor, and the RNs are the ones usually that administer IV medications. The LPNs are the ones that will take your vital signs and those types of things. I think my take-home point with nurses is, in general, there's always a charge nurse on the floor. So if something's not going right with the nurse taking care of you and stuff, you can always just ask to speak to the charge nurse. They're kind of there 24 hours on your floor, and they can really help direct you where you need. Is it a issue that needs engineering to come fix the air conditioning in your room, or is it something that the doctor needs to be called about for a pain pill that wasn't prescribed? So just be aware that the way I would escalate it is, always ask your nurse first for help if you're admitted to a hospital, and then a charge nurse. If that nurse isn't helpful, a charge nurse is designated for every floor to kind of just oversee all the patient care, and then they can be your advocate in helping you get your problem solved. But the nurses are, obviously integral, and most times, we have a really good working relationship with the nurses. Therapists that can be beneficial in the hospital setting, physical therapists work with weakness in the legs or problems with coordination with gait or walking. So if you've been in the hospital a few days and you're feeling like your legs are weaker and it's hard to move around, if they haven't thought of it already, ask to see a physical therapist. They'll get you out of bed, they'll get you moving in the halls and walking, they'll figure out if you need a walker when you go home, those types of things. The occupational therapist is really helpful for patients with the hand issues with scleroderma, because even if you're not there for a scleroderma related, ask to see the occupational therapist, because they're great. They'll figure out all the different, I'm sure you've heard during these conferences, all the different tricks that you can do to use different forks and utensils and things in a different way, and gadgets and stuff. So the occupational therapist can be useful. You can just ask to see them while you're there. Speech and swallow therapists can be helpful if you have issues swallowing. Wound care is really useful too if you have any open wounds in the hospital. You don't have to be in the hospital for that problem. They can see you, and they're really knowledgeable about what type of dressings to use, what types of creams to use. And so you can, especially in the hospital, my thing is that, patients are sitting there for 24 hours. You're getting you're seeing the doctor seeing you 15, 30 minutes, and the rest of the time you're just kind of waiting around. So it's a really good time to get these therapists to resources to work with you. Health educators are another resource. But while you're in the hospital, the dietitians, you can ask to see them. They can come talk to you about different issues with diet. If you have diabetes, they have diabetes educators. They have palliative care teams. If someone is really sick and you just need a lot more time discussing advanced care planning, end-of-life issues, you have palliative care teams. You have disease-specific teams. So if you have pulmonary hypertension or heart failure, they have teams that educators that can really help you figure out your sodium intake, your fluid balance, those types of things. So just be aware that all these people are there in the hospital. It's really the best place to, if you feel up to it, getting education and getting these therapists to get to come see you. Again, if you feel up to it and you're not feeling too sick to deal with all that. And like I was saying, the social workers are one of our most helpful people at linking patients with aftercare from the hospital. So when they get discharged from the hospital, making sure that they get their equipment, getting home health set up, linking them to community resources. So a lot of times with our oncology patients, cancer patients, they link them to the local American Cancer Society resources and all that. So they can really help link you to groups that will be able to help you when you leave the hospital. They can also help you with the financial aspects, get your financial planning, insurance information, forms, direct your forms. We get a lot of Family Medical Leave Act forms that the social worker can then fax to us or get to us, and we can help fill those out and all that. So they can really be a helpful resource. I think I'm, preaching to the choir when I talk about being proactive about your healthcare, because you obviously are a very selected group of motivated individuals. You've taken time and resource to be at this conference and learn. So, some of these things I want to just kind of point out to you that you can help you be even more proactive. Choosing a hospital, I'll talk a little bit about how you can do that now online. Medical trials and then staying safe in the hospital is another thing I want to touch on. This website, if you haven't been to it, it's really amazing how every few months when I go to it, it gets more and more information. 5-10 years ago, as consumers of healthcare, really didn't have any kind of way to compare hospitals, compare doctors, and all that's really changed with the internet. And there are now many different sites, but for hospitals in general, this is the one I recommend. It's through Medicare. It's called medicare.gov/hospitalcompare. And it's still in the early stages. I think it's still, it's not like buying a car or something where you can really compare everything exactly, but it really has a good summary of it has patient experiences, and it has different ratings based on patient experiences with different things. Did your doctor spend time talking to you? Did your nurses address your pain? So a lot of key questions that are important to patients. They have surveys of their experiences. They rate or rank hospitals and how quickly and how efficiently they take care of some common problems like stroke, heart attacks, pneumonia. They have a lot of information on elective procedures like hip replacements, knee replacements that are sort of standardized now, and you can find out what their infection rate is with those procedures. They have all those numbers up, and I think the key to me, if you're, for most of us, it's geographic. A Scleroderma center, if you have one, you're able to go to. It's been validated through the foundation. That most likely you're going to get really good care there. But if you don't have access to those things and you want to just you're going to a neighborhood hospital, what you can do is just scroll down, look up your neighborhood hospital in this website, and just make sure it's not an outlier in any of these areas. You want to make sure that they don't have a much higher infection rate than the state average or the national average. You want to make sure they're at least with the averages, hopefully better. So that's where I think at this point you can really use it just to make sure that where you're going to is in line with the national averages, and they're not an outlier. I think is very useful. If you have a choice of a few doctors, like the gentleman who earlier said, they have 4 emergency rooms that are close by to them, and someone needs a knee replacement, you can really go to these 4 hospitals, put them in, and kind of really go through which one has the least infection rates after knee surgery, which one the patient's surveys had the highest quality of care, their experience. So you can be a more informed consumer of your of healthcare. And so that's one aspect of it. I think the more important aspect that I've seen in the last 5-10 years of this all being available online and being more transparent is that hospitals in general have really focused on quality of care and all these parameters now. They've made it paramount that these things, because they know they get measured, they're out there on the web, they've taken initiatives to improve quality of care in the hospital. And I think that's what it's really forced all hospitals in the US to do, is really streamline their processes, try and standardize. Like he was saying, for emergencies, they really shouldn't have different processes. They should all be very similar in the common things. And that's what this has forced all hospitals to do, is really try and improve their quality of care that they're providing. This cartoon says, if it costs $1,300 a day to be in the hospital, how much is a 15% tip for the person who brings my meals? So that's the one thing about hospitals, one good thing. You don't have to tip anyone. As far as medical trials are concerned, the 2 websites I recommend for a general overview, if you're interested in participating in a medical trial, and especially again with scleroderma, when you have such a not as common illness, you kind of want to always be proactive. Somebody I was talking to at lunch said, well, they asked their doctor, because she had this stomach condition called gastroparesis, if there were any trials, and the doctor said, oh, he doesn't know of any, and she was like disappointed. I was like, well, you really got to go yourself and look through this stuff. You can't. There's just too much of this going on all over the country for us as physicians to keep track of. And really the correct answer for a doctor would have been to direct her to some of these websites that has this information. The Scleroderma website, our Scleroderma Foundation website, does a great job of trying to collect all the scleroderma trials, and they have a map, and you can just click on the state and see what trials are ongoing in your area. So that's very helpful. That's one way of looking at it. The NIH is much more comprehensive. It has almost every study. It's the repository for all medical trials in the US. So you can put in scleroderma and Raynaud's, and then it'll pop up 100 choices, and then you'll have to narrow it down, your search, by, first of all in the US, not international, unless you really want to look international, and then by state, and kind of figure out which is. So it'll give you a lot more information, the NIH. It'll cast a wider net, and you'll have to kind of narrow it down and kind of see. And what I would recommend is that you go through this information, see a few that are geographically possible, that are open, that you're interested in, and then take those to your doctor. Print them out and take them to your doctor and say, which ones do you think I should look into? Is it worth looking into any of these for my condition? Take them to your rheumatologist even. They can't keep track of all these trials. You really have to be proactive. And when I would definitely seek it, or it's great to just look and see what's out there, and if you want to enroll in a trial, but also if you feel like you're not getting any better with a certain condition and there's not much else to offer you, look and see if there's a trial that fits your condition and whether you want to be part of it. One more thing I want to touch on is staying safe in the hospital. You unfortunately hear about all the complications and things that go on in the hospital. And a key thing that hospitals have been driving is really hand hygiene. Every time someone comes in your room and is going to be examining you or treating you or touching you, they really should be using hand sanitizer before and after. And that's a good, easy way to kind of see that they're doing what they're supposed to do. And you don't feel shy about telling them, hey, I didn't, can you use the hand sanitizer before you put that IV in me or something. So don't be shy about speaking up. It's okay to tell them to. They should know to do that. I would ask about every medication that is being administered. Even if the nurse hands you 5 pills or something, just say, okay, I want to just know what is this pill, what is this pill, what is this pill. And if it's something you're not accustomed to taking, hopefully the doctor had told you that they're starting a new medication or they're changing the dose, or just tell them, well, if the nurse can't tell you why you're on this medicine, then tell them, you want to just confirm it with the doctor before you take it. And you're not being nitpicky. You need to double check. We try and have system things in place to prevent medication errors, but unfortunately medication errors in the general medical community are the highest rate of any errors. So you really want to make sure. If you have a test, find out the result. Not, you might have an echocardiogram, an ultrasound, a CT scan all on the same day, and somebody comes and tells you, the echocardiogram was fine, but they don't mention what the ultrasound says, and you just figure, oh, okay, it must be okay because he didn't mention it. And you really want to ask them and write it down. You had an echocardiogram, you had a CT, you had an ultrasound. What were the results of each of these tests? And you want to specifically find out the results and be told, and if they're normal, great. But just don't presume that if they didn't tell you that they didn't. There's sometimes, unfortunately, when people have so many tests in the hospital, it's not until discharge that I realize that, they had the CT scan and it showed a little nodule in their liver, and we're going to have to recheck a CT scan in a few months or something. So you just want to be really proactive about the test results. The last couple of things: keep a notebook at the bedside. Write down everything in that. Write down your questions. Most, as hospitalists now, we keep a card with our photograph on it because, like it said, you see so many different doctors and stuff. So we have our photograph on our card so you can know, keep track of us. And, staple that to your book or attach the card to your book. Write down your test results. Write down what they told you of any, surgeries they're recommending or something. Write down the names. Tell them to spell it out for you and write it down. And then write down the questions that you're thinking of. So many times I walk in, they say, I had a couple of questions, but I can't think of what I wanted to ask you. And so, write down your questions so that you can. I love it when people are, come in and they've just got all their questions written down and their list and everything, and we can kind of get right to it. Try to have your support person. I know sometimes people want to stay with you at night and stuff, but during the day when your doctors are coming in, when you're having tests, procedures, it's really good to have your support person with you during the day. So the second person, just like anything in life, having your second person hear what they have to say. And it's great at this meeting too. We see so many caregivers and support people here, because when you're in the hospital and you're getting medications and you're not feeling well, it's hard to listen and understand everything, so it really helps to have that second person with you. This one says, it's a jungle out there, it's a vulture. Promise me, doc, if I don't make it, don't let my family anywhere near me. So if you're a vulture, maybe you don't want someone, but otherwise it's good. The last slide or two I have is the discharge process. Medical reconciliation is a big drive in hospitals these days, and that's to really make sure that the medicine, what medicines you're going home on, because unfortunately or fortunately, there's so many changes in the hospital, and we see patients that we discharge and they don't really know what they're supposed to take and what happened. So we really try and go through that. The doctor should be going through it with you. The nurse should be going through it with you. They should be handing you a list with your latest updated medicine. That information is only as good as what you gave them at the beginning, and that's why it's so important to give them the right medications when you came into the hospital. They should have follow-up information, and most of us fax a copy of a discharge summary to your doctors, all your doctors. I just ask them, who are your doctors that need to hear about what happened in the hospital, and we fax, in our system we fax them. I call the doctors if they need to know that you have to come back in 3 days and get this blood, this blood test checked again or something. I'll call them and speak with them personally, but most times we send them a written sort of communication that should outline what happened in the hospital. Speak Up is a campaign that the hospital accrediting commissions have put up, and I think it's a good way to just summarize what we talked about today. So, sir, you were saying don't be shy to speak up at all. You're not offending anyone, at all. And if they're good at what they do, they appreciate your help at speaking up. Pay attention to the care you get. Just be vigilant. Ask questions. Educate yourself about your illness. That's preaching to the choir here. You guys are awesome. I mean, I just love coming to these conferences because it's so great to see the empowerment of all of you trying to really educate yourself about scleroderma. Ask a trusted family member or friend to be around when you're in the hospital. Know what medicines you take and why, and ask every time a medicine is being administered. Use the internet now to research your hospital or your surgery center or your doctor even to just make sure that they're falling within the norms of what's expected. And then just you are the center of your healthcare team. I mean you should be participating in all the decisions. You need to be actively involved. And again, I feel like I'm preaching to the choir here, but you should not at all feel uncomfortable. You are at the center of the healthcare team. And communication is key, and that's why I love this cartoon, because this is what miscommunication can do. Yes, that was very loud, but I said I wanted to hear your heart. So try and avoid miscommunication. And my last cartoon is the doctor telling a patient, remind me again of which pleasures I haven't removed from your life. And, and I'll end there, and hopefully that was helpful. I think we're out of time to really have a lot more discussion, but I really appreciate your comments. I really appreciate your negative experiences in the hospital too, because of all of us, we can learn from all that as well. And hopefully, as we all move on in the future, we make it a better experience for everyone going through this.